Welcome, I'm Dr. Robert Glatter, Medical Advisor from Medscape Emergency Medicine. Today we have a distinguished panel joining us to discuss their important research for rapidly identifying patients with compromised lung function, particularly from COVID-19, patients who may be at risk for hypoxia, and therefore require not only supplemental oxygen, but also potentially a higher level of care. Joining us to discuss their important research is Dr. John B. West, Emeritus Professor of Medicine and Physiology, UC San Diego School of Medicine, who is author of more than 500 articles in the well-known textbook Respiratory Physiology, The Essentials. Also joining us is Dr. Cameron McGuire, pulmonary critical care physician and a clinical instructor at UCSD. Welcome to both of you, gentlemen.
Thank you. Thanks for having us.
Dr. West, I'd like to start with you. Obviously, triaging patients, we've traditionally used pulse oximetry. It's quick, it's easy. But there are problems with it, and some of the problem is that the skin type can certainly affect how we measure oxygenation. And because of this, it can certainly overestimate the need for oxygen, especially with COVID-19 patients, we experience this phenomenon. So if you can explain a new concept that you developed in your research known as the oxygen deficit, and then talk about pulse oximetry and how this compares.
So I agree with you that the pulse oximeter is a tremendous innovation, and there's no question that it's extremely valuable in triage of patients with COVID, for example. But the alveolar gas meter that we've developed is something that gives us more information than that. It uses the pulse oximeter, but in addition, it looks at the expired gas of the subject. The subject just breathes through a valve box, very easy to do. And we compare the oxygen in the air in the lung with the pulse oximetry measurement, and that gives us much more information. The pulse oximetry gives you a single number of the level of oxygen in the arterial blood, and that's very valuable. But it's even better to be able to look at the differences between what's happening in the lung and what's happening in the blood. And that is what the AGM is planned to do, and it works very well. It's very efficient. It's not a problem for the patient at all. The measurements can be done in a couple of minutes or so. And so it's an advance in determining the overall gas exchange picture of the lung, which is important in COVID because that particular virus, for some reasons that I don't understand, seems to particularly attack the gas exchange portions of the lung, the alveoli, and hypoxemia is very much a feature of it.
So in terms of respiratory failure, we always get concerned certainly about type 1 respiratory failure, but type 2 with hypercarbia would be a concern, and we might be missing patients certainly that might have a SAT, say, of 92 to 93, but certainly could be lower, but they also may be hypercarbic. And so with your device, I would assume that this oxygen deficit would be able to pick up this impaired gas exchange. Is that correct?
Absolutely correct. One of the readouts is the alveolar PCO2. So you can see immediately, just by looking at the screen, what the PCO2 is, and if it's abnormally high, that is obvious, and that is certainly one of the values of the instrument.
Absolutely. And Dr. McGuire, I'd like to bring you into the discussion and certainly have you talk about the device, and if you could demonstrate the device and talk about values that the device derives and how this compares in normal versus diseased tissue, and maybe talk about COVID-19 a bit.
Absolutely, yeah. So I'm going to actually turn my camera here so that everyone can see the device. This is the alveolar gas meter. I'm actually starting it from the very beginning, so I'm going to log in, which just takes about 5 seconds. And then once the machine tells you as a practitioner that you're ready to measure, it goes onto another screen, at which point you instruct the patient to breathe through a mouthpiece with a nose clip in place, as I'm going to do, and a pulse oximeter on the finger. So I'm going to stop speaking for about 30 seconds and get a measurement. So I'm going to stop data acquisition there, even though the machine is not quite at steady state. And we'll readjust the camera in a moment to talk about the values. But essentially, what I just did was what I asked patients to do in the study that we're going to discuss in a moment. Breathe normal tidal breathing as if they were ignoring my presence in the room, as if they were reading a newspaper or watching TV is how I instructed them. The machine gathers quite a bit of data, which we'll go through in a second. And the ultimate value that we were interested in was this concept of the oxygen deficit. The oxygen deficit is a surrogate for the alveolar to arterial oxygen difference, AADO2, or what we more commonly refer to as the AA gradient. Many of us learned in medical school from Dr. West's textbooks that there's a normal AA gradient and it increases with age. And that when someone is hypoxic or hypoxemic, there are 5 major causes, 3 of which manifest with an elevated AA gradient. So we essentially correlate the AA gradient to the oxygen deficit. It's been done multiple times prior to my study to validate this device. And we used the oxygen deficit essentially as a variable to predict the need for either hospitalization and or supplemental oxygen administration during hospitalization. The way the alveolar gas meter performs its function is on this screen. As a practitioner, you can watch a patient breathing in real time. And you can make sure that each breath is similar in both volume and flow. That's important because the alveolar gas meter makes some assumptions that a patient is in a steady state of breathing. The red line here at the top is the expired oxygen, and the blue line at the bottom is the expired carbon dioxide. So you can see that the values change during inspiration and expiration, respectively. You would expect the CO2 value to go up as the patient is expiring and the O2 value to go down, and vice versa on inspiration. This is essentially a quality control check that I would use as the practitioner. But the real benefit of the alveolar gas meter is in its output or its display. And unfortunately, because I stopped breathing, the display went away. But I can show you the general characteristics of the alveolar gas meter here nevertheless. So it gives you an atmospheric pressure and an inspired pressure of oxygen up here. And then it shows you the alveolar tension of oxygen, essentially in that semicircle, which is supposed to represent an alveolus. It then uses the end-tidal CO2, which it measures down here at 31. I was hyperventilating a little bit. And it does some fancy math to essentially extrapolate what the arterial oxygen is by using the pulse oximeter, as well as a couple of fancy equations, the Hill equation, and then a Severing-House correction. That is what gives you a PaO2, which is displayed as GPaO2 because it's not an actual arterial O2. It's a generated value. And the difference between the arterial and alveolar oxygen, the P big AO2 and the GPaO2 is the oxygen deficit.
So in terms of using this value, I would assume that serial measurements of this value are useful in assessing patients when they initially present, and then maybe if they start to have increased work or breathing, they decompensate. And other than your clinical skills, looking at work or breathing, accessory muscle use, and so forth, and someone's still satting 90, you'd like to know, would this device be more predictive, A, for the need for increasing oxygen requirement, and B, the need for admission. So are your studies looking at these variables rather?
Absolutely, yeah. So the study in question, the one that I presented at ATS, along with many of my excellent colleagues, and will be writing up in a manuscript. Actually, the manuscript is in process now, looked specifically at using a single value of the oxygen deficit at one point in time as a triage tool, and its discriminative ability to predict the need for hospitalization and the need for supplemental oxygen at any point during that hospitalization. Most patients were enrolled within 24 hours of presenting to the emergency department, although many of them within a few hours of arrival. They had dyspnea, and probably 70% of them were still on room air. A number had been placed on a small amount of oxygen for comfort, but all measurements were obtained on room air. So I actually took patients off and allowed them to breathe quietly at room air for at least 5 to 10 minutes to ensure that there was no residual increased oxygen tension in the alveoli. Now, what you asked about, I think, is actually much more interesting, and would be how are serial measurements over time informative? Our IRB was written such that we are able to do that. But in the multiple surges of COVID that we have gone through in this country, with overwhelmed ERs where patients are spilling out into tents on the parking lot and oxygen resources are sometimes scarce, we really wanted to look for a single point discriminative tool that could help us help our ER colleagues decide potentially if someone is safe for discharge or maybe needs a little closer monitoring or even admission.
And in terms of sensitivity and specificity, do you have any values that reflect that in terms of an overall sort of a snapshot or from the study itself?
Yeah, so we generated receiver operating characteristic curves for both admission to the hospital as well as need for supplemental oxygen. The value for the area under the curve for hospital admission is a little over 0.7, which is very good. Not the best in the world, but still quite valuable. And I think was actually those data were actually somewhat skewed by the fact that 3 or 4 patients who presented with COVID had many other medical comorbidities, and their primary care team wanted to admit them for sort of observation purposes. But the real utility, I think, at least in our study thus far, is in the need for supplemental oxygen. So if someone had an oxygen deficit of 40 or above, and the oxygen deficit tracks with the AA gradient, but actually is a little bit larger than the AA gradient. So an OD or oxygen deficit of 40 may represent an AA gradient of 32 to 35, which is still quite high. But an oxygen deficit of 40 or above predicted a need for supplemental oxygen at some point during that hospital course with essentially 99% accuracy. The area under the curve of the receiver operating characteristic curve was 0.99.
That's quite accurate. Yeah. And so, Dr. West, obviously arterial punctures are the way that I was trained. I never had, certainly technology that now exists. And that's how we did serial arterial blood gases to look at patients' oxygenation, their ventilatory status. This is a big advance. Just want to get your thoughts.
Yes, I mean, I agree with you. And I'm fortunate in the sense that I'm terribly old and I can remember when the earliest measurements were made. Richard Riley at Johns Hopkins, and together with a number of younger people whom I knew very well, developed the arterial puncture technique. Actually, he was the first person to measure the PO2 in blood using a bubble technique, which is now no longer used because the electrodes, of course, were a very valuable invention and are used now. But I can remember, when I was a younger clinician, I measured the alveolar arterial oxygen difference, the AA gradient on lots of patients, and it was, of course, a valuable indicator of their status. And now we can do essentially the same thing non-invasively in a short period of time. It's, I think, a tremendous advance. So I can remember it right from the beginnings, way back in 1950 or so, when I first got into pulmonary medicine.
Right, because obviously silent hypoxemia or occult hypoxemia is a real issue, especially in COVID patients. And so, I think this is certainly applicable, with that patient population, but also other patients, maybe COPD, asthma, people with IPF, other, types of lung pathology. I wanted to also get into, the question of whether this device could actually have a role in looking for patients with pulmonary embolism, cor pulmonale, right heart failure, things of, that are not COVID related. Is there a role for such a use for your device in this capacity?
I think there probably is, although, of course, at the moment with COVID around, that's center stage, no question about that.
Sure.
So what is particularly being looked at the present time is the efficiency of pulmonary gas exchange, which is destroyed by COVID. And that's where the most of the work is going. But you mentioned, for example, pulmonary embolism, and there's a lot of people thinking about that. Pulmonary embolism will affect particularly the PCO2 and by looking at the difference between the arterial value and the expired value. There may be information there that, in my, as far as I know, that has not been looked at yet, but it certainly will be. I mean, I like to think of this as an all-encompassing way of looking at the overall gas exchange of the lung, where you're looking both at the gas side and the blood side at the same time and comparing them. And I think there's a lot of good stuff there that hasn't yet been unearthed, in my opinion.
Absolutely. And Dr. McGuire, I understand there is some research that has been done on pulmonary embolism, at least a poster that I am aware of from your institution. I'm not sure if you directly participated in the research. I don't know if you can comment on that. There was a case study or report that I did review.
Yes, I did not participate directly in that study, but I am familiar with it. And the primary author shared his poster with me. It was a really excellent study. I think there's quite a bit of untapped use here, not just in pulmonary embolism. I think there are a number of uses, as you alluded to, with COPD, core pulmonale, IPF patients being other great options. Within the PE realm specifically, I think, the mechanisms that underlie hypoxemia and hypoxia in PE are very unclear at times and multifactorial. And as Dr. West mentioned, CO2 is probably of greater importance. We still don't have an excellent way of non-invasively assessing arterial carbon dioxide content. But as Dr. West mentioned, if you have an abrupt change in your alveolar CO2 tension and the circumstances seem appropriate for pulmonary embolism, I think it would still be a useful tool for trying to diagnose pulmonary embolism, even if the oxygen deficit is not as impaired. If there is a significant change in the carbon dioxide tension, that could be thought-provoking.
Understood. And I want to also discuss the issue of skin type and skin color and how measurements, for example, of oxygen deficit may be more accurate, certainly, than SpO2. Are you aware of any studies or ongoing research or current, investigations that look at or are looking at oxygen deficit as a surrogate marker instead of relying on SpO2 in darker skin types and certainly in racial and ethnic diversity?
Yeah, this is a great question, and thank you for asking it. It is actually sort of one of the things that I am most interested in and passionate about studying prospectively moving forward. There is a group in Boston that is using the alveolar gas meter in Uganda, but it is more as a point of care triage tool. They're not comparing it across different racial groups as far as I'm aware of. But I think that the oxygen deficit provides quite a bit of additional information for two major reasons. One is we rely on a pulse oximeter just as every other hospital or medical device does. And there's excellent data last year from Schoeding's group in Michigan in the New England Journal, and then a different group this past year in JAMA IM showing that the pulse oximetry in isolation overestimates the arterial oxygen content in patients with darker skin tone, both Hispanic and African Americans, quite frequently. We would be sort of hamstrung by the same issues if we relied on our pulse oximetry alone. But because we have the alveolar oxygen tension, I think we get an extra bit of insight. And what I have said multiple times to some of the trainees that I work with, as well as my primary research mentor, is if you have an elevated oxygen deficit in a patient with darker skin tone, that deficit may actually be underestimating the severity of the deficit, right? If the pulse oximeter is overestimating the P little AO2, but the P big AO2 is low enough that the oxygen deficit is elevated, then the oxygen deficit may actually be more elevated than we're seeing. And so I think using this prospectively to look at the difference between, say, a Caucasian patient and an African-American patient, and maybe a patient with a skin pigmentation somewhere in the middle, would be a really beneficial tool because of the utility or the rapidity with which you can get a measurement from this device. I think it would be a great way to think about how to triage patients who we often have sort of neglected unintentionally due to the limitations of our technology.
Absolutely. And Dr. West, I wanted to get your thoughts on this too, about addressing a huge problem, obviously, with skin type and skin color and racial and ethnic diversity, because the literature has exploded in the last several years. The FDA certainly is aware of the issues ongoing with pulse oximetry, yet they haven't really formally, made inroads to address the problems that exist with current near infrared technology that pulse oximetry is based upon from the early 70s. So do you foresee that your device will in some way supplant the need for standard pulse oximetry going forward in the next several decades?
My guess is you wouldn't supplant the need for pulse oximetry because it is such a simple, powerful way of measuring arterial oxygen saturation. But I agree with you that there's a tremendous opportunity here to clarify what happens, for example, as skin color changes. I would just say that I think the potential is there and it hasn't yet been thoroughly mined.
Well, that's good to hear, because we know that certainly pigment plays a role in terms of, when the pulse oximeter, and not just oxyhemoglobin in terms of the LED and the infrared absorption. So that's very, very important. I want to just wrap up, and maybe if each of you could provide one or two pearls or takeaways from our discussion. Dr. West, I'll start with you.
Well, of course, I'm particularly interested in further development of the alveolar gas meter, and I personally think it's got a tremendous future because it is very simple to use. It is very simple for the patient. There's no arterial puncture, and I can remember vividly problems with arterial puncture during my period as a physician. It has the advantage of looking both at the blood side and the gas side, and there are not many investigations that do that, but it's going to be up to people like Cameron to do that. And I'm jealous, actually, of the opportunities. I wish I was as young as Cameron, as I was a long time ago. And I'm sure it will be extremely interesting to follow this up.
Absolutely. And Dr. McGuire?
Yeah, well, I just have to say thank you, Dr. West. I grew up reading your textbook, and so the fact that I've had any success to this point is because I get to stand on the shoulders of giants such as yourself. I think one takeaway point is that this device, or devices like it, if there are others in development that I'm unaware of, have already been well validated in the outpatient setting. We have now validated it in the inpatient setting of patients who are sort of rapidly changing with active parenchymal lung disease. And I think that that's really a beneficial thing moving forward. I think we've alluded to a number of untapped areas of research. And I think that the use of this device to help triage, help with patient decision-making, could be applied in a number of different arenas, including discharge planning, need for oxygen supplementation at home, pre and post therapy, and how someone's parenchymal disease improves or changes, or how someone's pulmonary vascular disease improves or changes after the implementation of therapy. I think there's a wide swath of research to be done, and I'm super excited to be sort of at the cutting edge and able to have access to something like this to help with decision making.
Absolutely. And I think, as you allude to, length of stay and throughput are important, certain metrics that we're looking at, and this device certainly holds the opportunity to address that. I want to thank both of you again for your time. This has been very informative, and I think our audience will truly appreciate the value of discussing such an important topic. Thank you again.